Thank you everybody for joining. We can got a good quorum here. So let's see, it's I guess 2 minutes beforehand. Maybe we'll just go ahead and load up Toby's lecture just so we're ready to go at 12. But this is our first Fellows Corner Hangout. So we hope this is going to be a continued success, and we're really excited to have Dr. Toby Coomer here to present to us the topic of contrast-enhanced ultrasound, which I think is probably a topic that not many of us get to teach firsthand to our fellows and to our other ultrasound learners. So great. So I think what we'll do is, at least to start with, if anybody has questions, go ahead and type them in under the chat icon at the bottom. And if it seems like we need to have more of like a verbal discussion, there's not too many people, we can maybe try that. This is a little bit of a trial and error, but all right. Well, great. Let's get started. Take it away, Toby.
Perfect. Can you hear me? Can you hear me okay? Or
Yep, I hear you fine.
Okay. Let's get this started. So hello everybody. It's great that we can do this because I'm very passionate about that. Some of that, if you've been to AEUM, it's a little bit a repetition of what I'm going to talk about, but so let's see if this works. We tried it out before. Okay, perfect. Yeah, so I'm going to talk about contrast-enhanced ultrasound, and first I'm going to talk a little bit about the basic principles of contrast-enhanced ultrasound and the techniques and equipment that you need. And then the second part is the CESA paper. It's one of many papers that has been done on blunt abdominal trauma, just to talk a little bit about the specifics and the research of that. So I have no financial disclosures. I'm going to talk heavily about off-label use of ultrasound contrast, and it's going to come up what is actually approved for by the FDA and what's considered to be off-label. And we can talk a little bit about the off-label stuff, but remember that a lot of things, especially in peds, you do is off-label. So let's talk about some contrast principles, and I assume most people, because it's the Fellows Hangout, have a fairly good understanding of ultrasound imaging in general. So contrast-enhanced ultrasound is based on using little microbubbles. Initially, actually, they used air without any additives or anything like that, but that dissolves pretty quickly into plasma. So modern microbubbles, they are about a 3 to 5 micrometer in diameter, so about the size of an erythrocyte, and they are consisted of an inert gas or gas. The older generations are air, the newer generations are more the inert gases, so sulfur hexafluoride or perfluorine. And then it has a stabilizing shell, either lipids or albumin or polymer, that prevents it from getting taken up into the plasma immediately, and it makes it survive the transpulmonary passage when you inject it intravenously. So the interesting thing about ultrasound contrast is that it's strictly intravascular. It's actually one of the very few, if not the only, medium that is strict intravascular. CT contrast is actually small enough that it can cross the membrane and actually kind of diffuse into the tissue. That's why you get some enhancement in inflammatory diseases, but ultrasound contrast really stays in the vasculature. So why can ultrasound machines, or how can ultrasound machines pick up the signal, and what makes these bubbles shine so brightly? There's two major principles why that is the reason. The one is impedance, and the other one is oscillation. So if you think about impedance, I think most people probably know what that is by now. Impedance is the resistance of a medium for the ultrasound waves. And you have, when we do medical imaging, we have air on the one side with very low impedance and bone with very high impedance. And then all the tissues in the middle are kind of almost the same. They have a soft tissue average of 1.58. And whenever an ultrasound beam encounters a difference in impedance, it will reflect. So as you can see, if you look at soft tissue average and then air or the microbubble, there's a strong, large difference of impedance, so that serves as a large reflector. So that's the one reason. And the second reason why we can see them so brightly is oscillation. So as the ultrasound, the microbubble is exposed in the ultrasound field, it gets to, it starts to oscillate, and basically it contracts and expands depending on how the pressure is in the sound wave. Fortunately, the resonance frequency where the oscillation is the strongest is within the medical range. That's why we can use them. It's usually between 2 and 15 megahertz, but actually the main frequency of most of the bubbles are between 2 and 6 megahertz. So really good for lower frequency imaging that we're doing. One key principle to know about these bubbles is that the contraction and expansion are not equal. So which leads that they have a non-linear behavior, which can be used to detect the bubbles later. So I would remember that. And then this whole principle of oscillation enhances the echogenicity by a factor of 1,000, just compared to just looking at the impedance difference. But the oscillation is really what makes them so easily detectable. Here's just under a microscope, you can see in the pressure wave, it kind of extracts and expands and collapses. And the microbubble oscillation is dependent on a couple of factors. 3 of them you actually have some control over with your machine, which is the frequency, the amplitude, and the PRF, the pulse repetition frequency. The type of gas and the shell properties are not under your control. But with the first 3, you can actually enhance your image and optimize your image. So what happens with the microbubble as it's exposed to the field, initially when the MI is low, you actually have a linear oscillation where contraction and expansion are the same, but then as you go higher, it becomes nonlinear. And then if your MI is too high, then they start to, they get destructed in their fragment and they get cavitation. And then they emit a very strong signal at the end, but usually, typically, we want to have them at this stable cavitation where they oscillate nicely. So the ultrasound machine is basically a little bit like Where's Waldo? Out of all the noise, it has to find the one bubble, and it uses different techniques to find him out of a lot of things that look very similar. And the way that there's a couple of techniques that have been developed to do that, and most of you are probably familiar with harmonic imaging. If you're not, you definitely need to read up on it. I'll talk a little bit about it. This was the earliest, harmonic imaging was the earliest technique to find it. And there's 2 other major techniques that are used. It's pulse inversion imaging, which also is called phase modulation or amplitude modulation. I'm going to talk about the first 2 because they're most important ones. But to be honest, they got so technical in the last 2 years that there's a lot of very fine variations and very complex medical models how to find those bubbles. But I think that these 3, for any fellow, probably should know how they work. So for harmonic imaging, if you remember, what happens is the ultrasound sends a beam out in one frequency, but receives the harmonic frequency. Most of the time, it's going to be the second harmonic that we're looking at. If you think of it very simply, the bubble sends out a pretty strong second harmonic, and if you just use a high-pass filter, you could just filter out that and just listening to that and get a very nice signal from this. And what it does, it decreases the reverberation artifacts, side lobe artifacts, increase your resolution, but overall you have now a very narrow bandwidth, so you lose a lot of information, but it does increase your signal to noise ratio. The problem is that a lot of tissues, as you know, also produce second harmonics. That's what we use actually in a lot of imaging when we do THI or tissue harmonic imaging, where we try to decrease that those artifacts. So it's actually not the best method to distinguish tissue from the bubble, but this is one of the earliest methods that have been used. The more modern ones are dependent on that the microbubble is a non-linear or has a non-linear echo response. And if you look at the first line, if you have a what the ultrasound machine does, if you look at the first column, it sends out an incident pulse, and immediately afterwards sends out an inverse pulse. And if you have a linear echo, that's the middle column, like a normal tissue, they will cancel each other out because they respond linearly. So what you send in is what you get back. And so the sum is 0. But for a nonlinear echo on the right side, that would be the microbubble. The response for the the one incident pulse and the other one, because it's a nonlinear reflector, is not zero. So you actually cancel out everything except for the bubble, and that's what we're doing in the imaging. And it is a little bit sensitive to tissue movement, but in modern techniques, as you can see, it can be compensated very well. And what I'm not going to talk about is amplitude modulation, which is the same thing where instead of sending a different phase, like inverted wave, you basically send a stronger wave and less strong wave, and they cancel each other out. But those are the three methods that we use. So this is what contrast-enhanced ultrasound looked in 1968 when it was first described. What they did, this is actually an M-mode image of the aortic root. And as you can see, when they injected small air bubbles, you suddenly get a very strong signal. I know it doesn't look like anything that we're doing today, but this is what they did to look at the aortic root back then. So that's what contrast imaging was in 1968. And this is what it looks like today when you inject the contrast. I don't know how well the video plays, but you can see almost every single bubble can be detected. So this is the size of an erythrocyte. What you can see is on a normal contrast image, on the left side, you almost have like a subtraction angiography. On the right side, you have a somewhat degraded B-mode image. And the reason that's so degraded, looks so fuzzy, is that you have to keep the MI low so not to burst the bubbles. So if you look at the right side, the MI is 0.15, which is way lower than what we usually use. So typically, there's just, for any contrast imaging, you would do normal B mode first and then go into contrast mode, because the B mode is just for your orientation, and you probably don't get much detail with the B mode image with that. So the other thing that you can do with contrast enhanced imaging, and that people have been studying, is you actually, by looking at a region of interest in your organ and record how the brightness is in that little square over time, you can get what's called time intensity curve, a TIC. So you pick a region of interest and then you record what happens over time, and this actually can give you information how well the organ is perfused. So the overall brightness in that little square is equivalent to the blood volume, and then the velocity and the blood volume give you something, information about the perfusion. And there are some models where you can actually calculate perfusion by milliliters per minute. So I think there are some interesting research applications that this could be potentially useful for. So what happens if you expose a contrast, all the bubbles, to a high MI field? All of these machines have a flash button. It sends out like a 2 MI or 1.5 MI impulse. It deletes all the, cavitates all the bubbles, and then you can look at refilling of the organ, actually do remeasurement of perfusion. So if you look at the left side, right now there's all bubbles in the spleen, and then when we hit the button, they all go away, and then they refill afterwards with that. So that's what happens when you hit the flash button. And there is, for some cardiac application, because they do have some acoustic pressure effects, there's some interesting cardiac application where they try to do sonothrombolysis by setting high MI pulses and make the bubbles burst for STEMI patients before they go to the cath lab, try to open up the vessel while they're waiting for the cath lab to be ready. So what is the contrast exam? What does it look like? Not like that. First, you need a contrast agent. Second, you need a machine that has certain requirements. Third, there is you need to have the right transducers. There's some safety considerations, and then you need IV access for it. So what is the contrast agent? We talked a little bit about it. These are all the ones that are on the market in the world. There's only 3 of them on the market in the US right now. There's Optison, which is the oldest. There's Definity, and then there is Sonoview, which in the US is called Lumason. So when it says Sonoview, that's outside of the US. It's called Lumason in the US with that. And and one thing to note is, as I said, the major resonance frequency for all those bubbles are between 2 and 5 or 2 and 6 megahertz. We have transducers that go way higher, but then you need to do a higher dose, because you need bubbles that are smaller size, and you don't have as many in one standard dose. So usually you need to go higher with higher frequency. So the way you pick your contrast agent, I don't have any stock and anything. It's basically a combination of your practice and how you like them and how much they charge you for them. There's differences for the different contrast agents in terms of storage and in terms of activation. So Definity needs to be refrigerated and needs to use a vial mix. It's a little machine that you have to bring around and then put it in there, and then it's a little shaker. Lumason you can store at room temperature, and it can be hand agitated. And I can show you, I have one sample here. And then Optizon is refrigerated, but it doesn't need to be really agitated. You just need to roll it in your hand, and it is very fast. So as I said, we picked Lumason because in the ED, we didn't want to carry around the little shaker. Also, we don't want to keep it in the fridge. And it's nice that it's hand agitated, but some people have preferences in terms of image quality for any of the for the other ones. And it really depends on what you have in your formulary in your hospital and all those kind of things. So what about the machine? The ultrasound machine needs specialized contrast package on it, which mainly is low MI imaging, and then it needs these specific contrast imaging techniques. The next slide shows some machines, and this is definitely not an endorsement of any manufacturer. These are the ones that I know can do contrast imaging at the point of care. I have asked, it was about a year ago, the different manufacturers. This is really not inclusive, and there might be other ones where you can scan on battery with the contrast, but these are the ones that I know you can scan on battery at the bedside. Because if you look at the bigger machines, like one of the standard contrast machines for radiology is the Logic E9 from GE, which is a huge thing. It takes forever to boot up, and you can scan on battery. But if anybody knows of any other machines, I'll be happy to include them in the list. But this is the list that I know. For the Mindray MB case, as far as I know, that the contrast package is not commercial right now in the US, but you can potentially get it for research. So what about transducers? Transducers, these are the transducers that we have. You can see with wide range from 1 to 20 megahertz. We're obviously not going to scan at 20 megahertz with the contrast package, but you have a very wide range of transducers for all kinds of application for contrast enhanced imaging. The equipment usually has these imaging techniques. They typically have a timer, because if you're looking for any injury pattern or solid organ injury, you want to know, are you in the arterial phase? Are you in the venous phase? And then typically they have a button for the high MI burst, so that's easy to do. So what about safety issues? So all of the contrast agents have a black box warning from the FDA, which actually hindered a lot of the use and research and development in the US. While in Europe and outside of the US, it has been used for many years. The US was almost like 10 or 15 years behind, because they had a very strong black box warning that has been modified over time. And this is the current version, and they're the same for all the products. So you can put your favorite product in there. So it basically says that that there are serious cardiopulmonary reactions have been observed uncommonly after administration. And you should basically assess all patients for any condition that precludes administration, which is severe allergy to one of the products. And they recommend resuscitation equipment available. But what does the data show actually? So the commonly reported side effects for those are headache, nausea, and altered taste. It changes a little bit depending on which agent you use. If you look at the studies, actually, how safe is it? There's an Italian study from 2006. They looked at 23,000 abdominal studies. Out of these, they had 29 adverse events. 2 of them were serious. And then they had no fatalities. So 2 out of 23,000. China was last year came out. They had 30,000 studies done. They had 6 adverse events, and they also had 2 serious events, which are mainly anaphylactoid reactions that needed treatment, and they also had no fatalities. If you compare that to the severe adverse events of other modalities, contrast is about half, then has CT about the same, and MRI, and way less than antibiotics. So what you need is IV access, and typically what you want to do is you need a 3-way stopcock, and you want to have the contrast in line with the with the transducer, with the line, and the flush coming from the side. You don't want to have the bubbles go around the corner because the pressure can destroy the bubbles. So you really want to have it in line and then inject afterwards. It's typically at least a 20 gauge in the AC would be preferable with that. So the one thing is you really don't want to use a lot of pressure on those bubbles. So this is usually when you agitate them, it looks milky white. And if you put them under pressure, they all burst and then it becomes clear afterwards. So what are some applications for that? The FDA says Definity has one approved application, which is endocardial border enhancement for echo. Lumison is the only one in the US that has non-cardiac applications. It's endocardial border enhancement, but also focal liver lesions in adult and pediatric patients, and vesicoureal reflux in pediatric patients. And then Optizon is the same as Definity endocardial border enhancement. So everything outside would be considered off-label use. So what are some things that people have looked into in research? Some of them are really early and really experimental with that. It's for the heart, endocardial border, looking for wall motion abnormalities, looking at myocardial perfusion. For liver and gallbladder, look at cholecystitis or infectious diseases and trauma. Testes, torsion, hematoma, trauma. Spleen, focal lesions, splenic infarct, also trauma. Kidney, looking for abscess, renal infarct, infectious diseases, trauma, renal perfusion. Vasculature, aortic dissection, one of the main uses now outside of the liver is aortic endoleak detection, which actually has a higher sensitivity than CT. Look at improved DVT imaging, GI tract for IBD, MSK, compartment syndrome, soft tissue hematomas, and inflammatory arthropathies. Lung, looking into pneumonia and infarct. So it is a fairly wide range that I think is ripe to look into further application for contrast. So this is a little bit oblique apical 4 chamber view. It's actually not that bad, the endocardial border definition. Once you add contrast to that, you can see how nicely the endocardial border all of a sudden is delineated, and you can assess for a global systolic function or wall motion abnormalities. And if you look at the septum, it's not optimized for septum, but there are some bubbles in the septum, and if you would burst them, you can look at septal perfusion or wall perfusion for the heart. So just a couple of cases. There's a 17-year-old male that we had, status post a bike accident, hit a rock and fell off the bike, had a helmet on, no loss of consciousness, was not anticoagulated, had some left-sided chest and abdominal tenderness. And he was actually initially seen at an outside facility, and they just did x-rays, and then they sent him home, and then he came back later with ongoing pain. And this was the x-ray, which was basically unremarkable. And then we did a fast exam, and which was positive. I can pull this off with you guys because you're too smart, because it's actually not the case, because I couldn't find the real image. You can see that this is actually an ascites patient. We can see the liver angle is way around it. So, but fast was positive. And then when we looked at the left upper quadrant, there was the obvious free fluid below the diaphragm. There's actually already something that you can see in the spleen that looked abnormal, which is not as common that you can see something, but you can see the hypoechoic, area in the spleen. And I know I see there's like a lot of chat things, but the chat doesn't really show up here. So sorry, I'll take a look at that in a second. If you add contrast to it now, what happens is that first you kind of stare at the screen, because it takes about 15 to 20 seconds for the contrast to come up. Let me just see if I can advance this. So if you put color Doppler in, it's not very useful. You can see if there's any perfusion in there, but what you do next is basically you inject contrast, and it takes a while. As you can see, we're kind of waiting and waiting, and everybody stares at you and nothing happens. And then it takes about 20 seconds. You see the clock in the left upper corner. We had 15 seconds. And then all of a sudden, at 19, 20 seconds, you finally see See the bubbles come in first in the aorta, and then it goes into to visualize the spleen, and then you can see that there is a filling defect. I think I stopped the video. There is the filling defect within the spleen, which is abnormal. And what you also can see is there's no bubbles outside of the spleen in the free fluid, which means there's probably not any ongoing extravasation in that into the abdomen. So the patient got a CT, showed the same thing. In the spleen, you see this defect, you see the hemoperitoneum around it. So there's a lot of studies on now. This is from 2009. That ultrasound itself, just the B-mode imaging, is not very good at detecting solid organ injuries. The standard ultrasound has a sensitivity of 68. If you add contrast, you're at 84, which in newer studies is a little bit higher than 84. 36 renal for B-mode imaging, and 98 if you add contrast. And the spleen, similarly, 77% sensitivity, goes up to 93 in this study. So what about pediatrics? This is from last year. Pediatrics, they had it was from Armstrong in Boston. They had 45% sensitivity for a regular ultrasound, and then it went up to 96% when you add contrast for solid organ injuries. Some other cases, we are doing right now a study on actively bleeding hematomas. This was an 81-year-old male with abdominal pain. He had some right upper quadrant pain and swelling and ecchymosis after he was coughing. He just was an aspirin, not anticoagulated, and then he started to develop right-sided abdominal swelling ecchymosis. That's what he looked like when he came in. And then when we looked at his rectus sheath, this is a normal rectus sheath of a normal patient. You see the rectus muscle on both sides. And in his case, his one rectus sheath was very enlarged. You can see his hypoechoic hematoma within the rectus sheath. If you put color over it, it usually doesn't give you much of information. But then we CT'd him because it's part of the protocol. You can see the blush over on the side. So what we do in our institution, if we have a suspicion for an ongoing bleed, actually the patient gets scanned 3 times. So they get a non-contrast CT, that they get a arterial phase, and they get a delayed phase CT. So they actually get exposed to radiation 3 times. So if you use contrast, what you can see over time is kind of the bubbles come around, and then slowly but surely you will see that if you wait for quite some time, you will have contrast pooling within the hematoma. That's the white dot in the middle. Basically, there was bleeding in the hematoma. Because it took several minutes, we determined it was venous, which was consistent with what we saw on CT. Another patient, she was a 82-year-old female, left thigh swelling. She was on Coumadin, had left thigh swelling and tenderness. Again, there was a hematoma. The color Doppler didn't really help at all. And then when we use contrast, you can see that kind of the contrast is filling up in the hematoma below. She had a small arterial bleed with that. There's some other applications like scrotal pain. This is from the literature where contrast can help you distinguish necrosis or hypoperfusion, and then which area is actually necrotic in the testicle. So in summary, there's you can use at the point of care. You can use real-time imaging. It's repeatable. It's independent from renal function. You don't need any ionizing radiation. Usually, it has typically fairly good safety profile, and it's relatively low cost with that. There are some guidelines if you want to look at what people have done outside of the liver and heart. EFSAM has very good guidelines on non-hepatic applications, and I can share that link. This book is pretty good. It's from Hans-Peter Westcott in Germany. I can also share that link if you're interested in reading more about the background and applications and how to optimize your machine. And then there's a lot of other resources. AEUS has the ultrasound community. AEUS is dedicated to contrast imaging and has some good courses. And then ASE has some recommendations for cardiac imaging. So that is that part. And let me just go out here out of this, and I'm just going to, let me see if I can get this back and actually look at the, I just need to stop the share, sorry. Okay, and perfect, stop share. Okay, let me just take a look. And it's going to take, I know there's people that like texting. So, okay, anything that is, anything that I need to answer right now? Or you can also just like, just do voice right now because I'm just looking at that. So the one thing I can do is, so basically what as I said, we use Definity, this Definity. So just in case you wanted to know how to activate, it's actually pretty simple. So it comes in three things. It comes as the vial with the powder in it. It comes with a pre-filled syringe with saline. And then it comes with a spike. So what you do is you just take out the spike and you put it into your powder. We had some expired Definity. So you put it in your powder in there, and then it opens up like this. And this has a little cap that you twist off. I usually keep the cap because then you can recap it afterwards. And then you just screw it on the spike, and it comes with a little little plunger that you screw in. It comes all with the kit. And then you just inject it in the vial, and then you shake it for 20 seconds. You know, you do that, you stand there for 20 seconds and just shake it. And that's where this is the Lumason, sorry, I apologize. This is Lumason, not Definity. Definity, you put it in the shaker, and then you shake it for 20 seconds, and then it gets kind of milky white. And once you've shaken it, it's called agitated, and then it gets milky white, and then you just pull it up in your syringe, and it's 4.8 ml. And our protocol, what we do 2.4 ml on the right. If you do a trauma imaging, 2.4 ml on the right side and 2.4 ml on the left side. So right side meaning liver and kidney on the right, and left side is spleen and kidney. And then you're good to go. And what we typically say is it's good, I think, for like an hour, a couple of hours. You know, you have to kind of shake it up a little bit before you use it, but if you have it laying around for too long. So that's what Definity, Lumason looks like. For Definity, and the reason we don't use it, I can show you. Definity has this very, very heavy shaker. That's what it looks like. It's pretty heavy, and we didn't want to carry it around. But some people feel like their imaging is better with Definity, but that's one of the reasons why we don't use it.
Hey, Toby, somebody asked about cost. Do you know, like, per?
Yeah, so there is, as everything in medicine, there's a list price, and there is what your hospital negotiates. I can tell you that for, I think most hospitals, depends on, so the list price is somewhere around 170 maybe or something per vial, but most hospitals will end up between $100 and $120, or maybe a little bit less than that. But it's basically, it's about that. If you think about $100 per vial, then that's actually where you end up with the cost for one vial. So, but it really depends on, and the way, if you want to use it and start it, cardiology probably already has something. So just talk to them, you know, what they're using, and to the shaker for Definity, they will give it to you for free. So, any general questions or?
Toby, I'm interested in the question from Andrew Shannon. How does low perfusion or shock states affect contrast use, or is there specific timing tables that need to be used? You mean
if you're in a shock state,
yeah.
To look at yeah, nobody knows actually. I have not found, like, if you think about like a trauma patient with a low perfusion or like a sepsis patient,
yeah,
nobody knows. It needs to be researched. Especially there's some thought about that in sepsis, you know, your organ perfusion goes down before a lot of other things, you know, before your lactate goes up. So it'd be interesting to see, you know, is there a difference in organ perfusion in those states? Nobody has looked into it. So would be an interesting study question. you know, to look into. The one thing that people have looked into it and that we have looked into a little bit is things like compartment syndrome, you know, to kind of see if there's a threshold or so where you can estimate what the compartment, how the compartment perfusion is. But those are all still very experimental, and that makes it so great because there's a lot of research to be done, you know, for these kind of things. And any other question about just a general use right now? Otherwise, we can talk a little bit about the paper. Let me just see. Oh, how do you bill for this? So we right now, you can. So it's billable. It's even if it's off label, it's billable. And there's a good webinar and I think a paper by Richard Barr. He's a radiologist who addresses the billing question. When you start, you probably going to have maybe a harder time billing. It's billable, but depending on your institution, it might be a harder time to bill for it. But if it's in the formulary, you know, they're going to try to bill it to the patient. Yeah. So, the Armstrong study was a single site, but I know that Armstrong is they're doing a multi-center trial right now. I also know that CHOP does a trial. And how do we get IRB approval for ultrasound contrast studies? Actually, not that. I've done it in 2 institutions, and we have a very strict IRB. There's so much literature out there, and it's actually pretty straightforward because our cardiologists use it, and then our radiologists use it. And we basically, instead of putting the probe on the heart, we put it on the liver, and even cardiologists put it on the liver. So, and there's enough literature out there that you can argue, you know, it's not, it's not, I didn't find it that difficult. The one thing that you have to make sure is that you don't, that you get an IND exemption from the, you know, that FDA wise, that you do not want to use this for marketing purposes or expand the indications for the product, which we don't. Because then you would need an IND, but typically you can get exempt. So I have IND exemption for all my studies, and the IRB usually is pretty good. Like we haven't had any issues with those. Let's.
Tell me one more question.
Yeah.
Are you having to get confirmatory CTs, or when you first started, did you have to get confirmatory CTs, or did they just kind of let you have free reign?
Yeah, it's we don't have to have confirmatory CTs. But to be honest, you know, like even like I'm actually working with our radiologists pretty collaboratively, and we want to actually just to get more experience, we would like to see confirmatory studies, you know, because you know, you need to get experience, you know, it's like anything else, there's a learning curve with that, and you should have some confirmatory studies. There are now some cases, you know, that we had somebody in an outside ED that comes in, had outside CT, and we just wanted to look at their liver lesion and see if there's any ongoing bleeding. In that case, when it's very focused, we don't, and we can spare the CT. But typically in the beginning, you know, you want to have a confirmatory study with that until everybody feels comfortable with what you're doing. It really depends on your setting, I think, with that. Okay, so let me, let's talk a little bit about the paper. I don't know if there's any other questions that I can look through the questions in a little bit, but so I'm going to share just the paper. Did everybody some people read the paper? Let me see where I can find it. It is, where is it? Here it is. For some reason, I can share like a lot of things except for my Acrobat reader. Let me see if I can find. I was going to do the whole desktop, I guess. That might be a little bit confusing because of the so this is the paper. Can everybody see that? I hope. So if you, I hope you read it. So this is one of the studies. The reason I picked it because it had some interesting things and had a larger number of patients. There is a meta-analysis that we can talk a little bit about for blunt abdominal trauma. But basically what you will notice is that most of those studies, except for, you know, the Armstrong group, are outside of the US, because it has been difficult to ultrasound hasn't contrast hasn't been really taken off in the US until recently. So most of those studies are still outside the US, where the practice patterns can be very different with that. So this is an Italian study. So basically, just to go over it a little bit, basically what they wanted to do is they wanted to compare B-mode ultrasound and contrast-enhanced ultrasound in the detection of solid organ injuries of the liver, kidney, and spleen, as well as looking for free fluid. And if you look at the abstract, it's always good to read papers, pretty carefully. Did anybody notice any errors on the abstract? Because they actually had an error on the abstract. Just to make this a little bit more interactive. See if I can pull up the chat. There's the chat. Found it. Anybody found any error on this abstract? Okay. If you don't, so the only thing is they reported that the numbers were wrong. They said, so overall what they did is 256 patients, they came to their emergency department. If you look at the date, this is like 12 years old, they did this 12 years ago, and actually the technology has increased quite a bit. They looked at had 256 patients who came to the ED with lower energy isolated abdominal trauma. They analyzed, they underwent a normal regular B-mode imaging, contrast, and then multi-detector CT. And multi-detector CT was their gold standard. So the error that they had is they reported for free fluid for the B-mode ultrasound, they reported 41 out of 45. So their sensitivity for free fluid was, I believe, hemoperineum, sensitivity was 95. Where did I mark it? So that was 91% for B-mode ultrasound and 95%, but they reported in their abstract that they both were 41 out of 45, which doesn't make sense. It's actually 43 out of 45. They had a little typo in there with that. So basically what they did is in this paper, so 256 patients, out of those 256 patients, 84 had an abdominal traumatic injury. The way they used the protocol is, well, how we use it too, they used 4.8 ml of Sonoview, split them up in two 2.4 milliliter doses. The first couple of minutes, 3 to 4 minutes for the right side. Contrast lasts about 5 to 6 minutes, and then another dose for the left side. They had highly experienced radiology. They had at least 5 years of experience in emergency radiology with both ultrasound and contrast. They compared it to a 16-row CT scanner with that. And then they looked at these 2 different things. One, solid organ injury, and they looked at how good ultrasound is at staging them, how good contrast is at staging them, and then also looked for free fluid when compared to the standard. So what they found in the results, that actually 32% of their patients out of those 256 had a positive traumatic findings, which I feel like is high. I don't know, maybe we're scanning too much, but certainly probably anecdotally seems a little bit on the high side for me. What they found is that regular ultrasound, out of these 84 solid organ injuries, found 50% and found the free fluid in 41 out of 45 patients. And they had a false positive for hemoperineum with 2 young women with free fluid in the Douglas pouch. And then contrast ultrasound identified 81 out of 84 patients or injuries, and 43 out of 45 for peritoneal fluid. The interesting thing is, if you look at, let me just scroll down here. Let's see if that goes. There's a couple of interesting things about this study. First of all, if you look at table 6, the accuracy for detecting free fluid, I don't know what the gold standard is. You know, if the CT is the gold standard, you would suspect that this specificity is 100% as well. So I'm not really sure where they lost their specificity, because they didn't compare it to ultrasound or contrast, so they didn't elaborate on that. But the interesting thing is also about anecdotally, it doesn't not make much sense that contrast ultrasound would be better in detecting free fluid unless you had bleeding into the hemoperitoneum. Then I could see that, because as I said before, the B mode image is very degraded, you know, on the contrast side. So you would suspect that regular B mode ultrasound has a higher sensitivity for free fluid than contrast imaging. So I don't know if there was some bias, that they already knew the non-contrast images, you know, because they initially, the same operator did the B mode image and then went to contrast. But overall, unless you see bubbles in the free fluid, I don't really see how contrast ultrasound would be better in just detecting free fluid. But that's what they're reporting. They're reporting a sensitivity of 91 and for regular ultrasound, and then 95 for contrast. In terms of the solid organ injury is for regular ultrasound. CT obviously here has 100%, but regular ultrasound is 59, which is about what they reported on average in the literature, and then increases for ultrasound to 96% for that. So their overall finding was that that they had a fairly high sensitivity, but when they found, in terms of specificity, when they found a lesion, they recommended CT imaging, because they were unable, not as good as detecting. They were only 60% sensitive to detect ongoing bleeding, and then there was some complication like urinomas that they missed on one patient. So they recommended using this as a screening tool, and then from there go on and further characterize the lesions. There's some other studies that show that ultrasound has made some advances in that as well, and that you necessarily might not need that CT afterwards, but it's still fairly early, and it's still up for debate. So if you look at the overall, did anybody have any questions about that? Because I want to leave it a little bit of time for just a general discussion. Mainly it's a promising tool, but it's just a tool, right? So nobody ever would like forgo high-speed MBAs, because there's a lot of things that you don't look at. You can't see the bowel, you can't see the bone. Pancreas depends on the bowel gas. Sensitivity is actually not that bad for contrast ultrasound if you're very experienced, but there's a lot of things that you potentially could miss. So just because you have that tool, you should not, overvalue it. And I think there's a lot of research still to be done. Just very briefly, this meta-analysis came out last year, where they looked at 10 studies, and their overall pooled sensitivity was 98.1 for contrast, which, as you know, sensitivity is not clinically very useful. So what they report is a diagnostic odds ratio. I'm not sure how often you've heard about that. The advantage of the diagnostic odds ratio, it's independent from your prevalence of your disease. So it's the relation of the positive and negative likelihood ratios, as you know, are also independent of the disease, and just tells us something about the quality of the test. So they got 7, which is pretty decent. Greater than 10 would be excellent. 7 is not bad for a diagnostic study with that. So if you want to look, I'm not going to go into detail too much about this, but they did a pretty nice meta-analysis of contrast-enhanced ultrasound for detecting solid organ injuries in kids. So should we just open it up a little bit for questions, or about the study itself? And feel free to use audio, because I'm trying keeping up with the text.
Yeah, if people want to go ahead and turn their audio on. There's a couple of questions, Toby, I think in the last like couple minutes, if we want to start with those. So let's see. I don't know. One thing I was wondering is, do you know if in Europe they're just using contrast enhanced ultrasound after trauma, and then if it's negative, they actually won't do a CT?
They do. It depends on site and center. They're in general, yeah. I don't think anybody in the world except for there's this one crazy guy who is in Davos in Switzerland who has all the skiing accidents. He's actually internal medicine trained. He has the largest number of traumatic injuries done by contrast, and he does not do a lot of CTs. So he's a great guy, but he just does that. But basically, I think most people in Europe, and Europe is, I'm from Germany, so it's always a little bit, what does Europe mean? But basically, I think everybody with a high speed mechanism, they would do a CT. They might do a contrast study before if they have time, but usually should go to CT. But I know about several centers that they do the contrast, and depending on what their suspicion is, but then they leave it like that. They wouldn't, like, even if it's positive, they feel like so confident that contrast can depict their lesion that they would not go for CT afterwards. So I think there's a subgroup of population, especially in peds trauma, which is actually a lot of focus of research right now, where it really could make a difference, in terms of radiation sparing.
And do you have a sense, just from your experience, is this something you think that the average emergency medicine point of care user would be able to have good numbers for? Or
I think it's useful. I think actually where I would see it first is if you cannot get a good estimate of your EF. I think the cardiac probably would be the first to get comfortable with contrast. And then later, I think for a while, it's probably going to be specialized because it does need special training. And just knowing how some of my colleagues that are like, I'm like happy if I can do a fast exam sometimes, so adding contrast to the mix might be a little bit of a long stretch, but I think there is a role. I think there is definitely a role in pre-hospital when you're away from CT, if you think about like military settings and things like that. I think just adding it to the fast exam, I think gives you a lot more information, but I think it will take some time, for everybody to do that.
Yeah, I mean, I could see costs being somewhat of an issue too, since this is like,
there's cost involved.
Yeah,
definitely. But we have, for us, in terms of where we see use is to decrease amount of re-CTing, because we're a large referral center. So we get people in that already have their lesion characterized on CT, but typically it takes a couple of hours. Let's say they're in an outside hospital, it takes 2 hours to transfer, and they had a blush on CT, and then they come to us and you want to know, is it still bleeding or is it not bleeding? In that case, I think it has a good role because you can define the lesion, and you can find the lesion and just look for bleeding, which is not that difficult, and then make it, because we used to, or we still do, quite a number of repeat CTs, for that. Other areas outside of the abdominal trauma where personally I think it's useful. It's, the hematoma, obviously I believe in it because we also doing the study. We have some cases where I had patients with a wedge-shaped infarct on X-ray, and already all still, their creatinine was 5, already all still wouldn't do contrast, whatever you think about that controversy. But we could show, like, on contrast ultrasound that had immediate perfusion of the whole segment of and was basically pneumonia, ended up being pneumonia, which we thought, not infarcted lung. So things like that, I think there's a lot of interesting things to look into for that. And then dissection, would be another thing for that. And I think, and Jason had a couple of good cases in terms of, if you have your alcoholic and they come back and they always have free fluid, and you want to kind of know, do they have any new injury to that?
What about tissue perfusion? Is that like something that contrast enhanced ultrasound could look at? You had mentioned
I think so. So yeah, so I think there's some couple of interesting things that you could look into in terms of if you think about organ perfusion and sepsis or whatever, you know, could that be a role? If you think about, sometimes I don't know how often you have these, where I use contrast, sometimes I get these reads where a radiologist says, oh, this could be a renal infarct or contrast timing, you know, bolus timing. Do you ever get those? I get this like fairly frequently. No, not. So if there's a question, is there a renal infarct or is it just the timing of the CT contrast, you know, then doing a very quick focused ultrasound contrast can give you the answer very quickly with that. In terms of other perfusion, compartment syndrome would be the other thing, you know, that I might think of. Basically looking at the perfusion of the compartment as a muscle perfusion with that. Nobody knows. There's one study on looking at compartment syndrome. So you guys all should do it.
Yeah,
Try
no,
it.
it sounds like there's
Research.
tons of possible applications for it. So it's yeah, I think it's kind of wide open.
Yeah, exactly. So, and I think it's totally feasible, you know, to look into. I don't think it's, you know, outside of what we can do and what we know, especially for fellowship trained people, what we know about ultrasound, because we are, you know, experts of ultrasound. So I think it's just a tool that we should explore. You know, it's one of those things everybody gets cited, you know, and then comes the whatever it's called, the trough of disillusion, and, you know, and then it kind of finding some areas where probably it's going to be useful, you know. So we're looking at there's other different things that you can look at in terms of you know, retinal artery occlusion, like perfusion of the retina and things like that, which are pretty interesting.
Toby, do you know of any military studies going on, or
I do not.
austere environments? Because I wonder about, because the machines that are compatible right now look like they're the less durable, higher price point machines. So
Yeah. I don't know of any of military studies. I don't know if the DoD is funding any of the pediatric studies, you know, if they have any funding in civilian areas. But as far as I know, there's nothing out there right now.
or even like like global health.
Yeah.
projects.
I don't think there's anything out there. Yeah, if you say durable, I think you probably mean like probably Sonoside, right? I mean, they're always known as being,
Yeah, that you can kind of pack up easily and
yeah.
toss
I mean,
around.
the M9, you know, if you look at the Mindra M9s, the laptop style, you know, I don't know if you consider that a durable machine, but it's definitely higher priced than any of the other ones, you know.
Also, how like shelf life of the, like if you were trying to take it into these environments, shelf life of the contrast agents, like how easy do you think it would be to take them into these
I think
settings?
the shelf life is a year or 15 months, I think.
And can do room temperature, nothing.
Yeah, I said, I think I had it in the talk. I think it's 15 to like 30 degrees. I think it's the optimal temperature, and can be like 6 to 30 or something.
Okay.
30 for 40, something like that. I could look at there's the package. I have the packaging insert, but yeah, it's something like that. I think they say, you know, keep it at like around
A reasonable temperature.
15 to 30 degrees, but can be briefly in other and higher or lower temperatures with that. Yeah, it's in the packaging insert how much you can actually use it for. I don't know right now where it is, but yeah, it's about that. Yeah, it's definitely interesting. You know, if you don't have CT, you know, if your only other alternative is regular B mode ultrasound, you know, and you can use contrast and get, you know, almost CT high sensitivity, you know, that's certainly preferable for just having B mode ultrasound, you know.
And Toby, just for like other people who might be interested in trying to do this at their shop, how did you get, I guess, maybe the funding to have access to it? And then like, was there a separate credentialing process that you had to do there? Or if other people are using it, how did you actually make it happen?
So different ways. So I started doing some things at Brown where I just collaborated with radiology. So the good thing is that radiology is not ahead of you. You know, they actually might not even use it. So you can actually be ahead of radiology. So so there was no credentialing for me, because the radiologist who just had started, our radiologist just started 7 months ago or 6 months ago. And there's no, for us, there was no credentialing process. So the way I started was actually to partner with radiology in the beginning. That's what I did at Brown, to have a study with them. Here, I've been involved in for a little while, but you know, I went to a ton of courses. If you have a lot of CME money, there's an excellent 4-day course in Munich. It's in English. It's a European course, or an international contrast course to get everything in 4 days. It's fantastic. But AEUS has courses throughout the US where you can go and they will teach you all about ultrasound. It's not a hands-on course. If you want to get hands-on experience, CHOP has this visiting program where they invite you to go to CHOP, and they do, you can observe, or you can be there when they do studies on kids, a couple of them. And so they're fine having non-radiologists come and do these. In terms of getting contrast, the first thing I would do is find out what you have in your formulary. It's so much easier once it's on formulary than what's not on formulary. So everybody has something on formulary because cardiology is using it. So if they have Definity, I probably would start what's on, rather than try to get Lumison on formulary, I probably would start with Definity and get the shaker. And then, you know, the easiest thing for those things is probably in the research setting. You know, it's like I feel like that's where you get the least amount of pushback. If you say, hey, I have a valid research study and we're doing this, getting radiology on board or letting them know might be helpful, but also depends on your situation. We have a very good relationship with them, and they're helping me enrolling for one of my studies. So they use the same protocol. And you know, to be honest, there's not much overlap with anybody else unless you do cardiac imaging. You know, radiologists, they're not very interested in traumatic injuries, because right now, at least, because they're so preoccupied with their cancer and their liver lesion stuff and all the things. So using something that they don't have access to, like my hematoma patients, they don't really have access to them very well. You know, doing your thing, I think it's fine. You know, I think I'd rather, like, I always over communicated it rather than they finding out, you know, oh, I'm doing contrast studies. So I knew, like, right from the beginning, I always had radiologists on my IRB, you know, and that helps, I think, just strategically, just thinking politically, but it really depends on what your environment is. You know, I think there's some hospitals where they couldn't care less, you know, but here we just try to play all nice, you know, in the sandbox. And and so they knew I'm going to do this study. They knew when I went through the IRB, they didn't have any issues, but also because right now they don't have this feeling of an ownership of contrast, because they're just starting. And our cardiologist, as long as it's not the heart, you know, we're using it for a heart, but as long as, you know, they only care about the heart. So yeah, we only have a discussion with them if it's about the heart.
Okay. Yeah. Somebody did write in to say that a lot of credentialing committees, they say that as long as it's being monitored by the IRB, they don't necessarily need a credentialing. So that's maybe a good way to begin.
I think research, just do a small research study, you know, and even if it's just like feasibility or whatever, you know, that's by far the easiest. If you can say, hey, the patients are consented, it went through the IRB, we have IRB approval. People rarely block research, you know, I found that. Yeah.
Awesome. Does anybody else have any comments or ideas or questions?
Perfect. Just go out and
awesome. Do it. Yeah, thank you everybody for turning out. It was a great first session, and thank you again, Toby, for taking the time to present all this to us. It was really, really interesting. Good overview.